Okay, it's still good morning out here in Anaheim, California, to my sisters and brothers joining us here at the Cancer Awareness Stand Down Workshop, and to our leadership all across two great countries for our second live webcast broadcast of our workshop. This morning we had our workshop on post-traumatic stress disorder. We had a full house here where over 1,600 of our leaders have gathered this week to do the work on behalf of our members, to receive the education, instruction, and the skill sets that you need to be able to go back and do the very difficult job that I talked to you about last night, that I know that you do every day. I'm very pleased that in our first webcast streaming live this morning, I'm told by our E18 production, by the way, your own production company, E18, from our own studios at headquarters in Washington, D.C., is able to bring this to our entire international. I understand we had as many as 1,200 that streamed in to catch this morning's presentation, and it was consistently at about 450. The point being, just another way that this IAFF of yours is not only trying to reach the 1,600 of you from across the United States and Canada that are here, but now providing the ability to reach out across our two countries to our leaders everywhere who are streaming in. So welcome to all of you. And I want to, the proper introductions will be made in a moment, but I certainly want to recognize our Director of Health and Safety, Jim Brinkley, does a terrific job working with our assistant, Pat Morrison, in our Health and Safety Division. I really so pleased and appreciate Dr. Weaver for being here with us, and she's not here with us today. She has been doing work on behalf of this IAFF, our members, our affiliates, for over a decade, and doing extraordinary work in the area of presumption and in so many other important areas that go to the health and well-being of our members. And to our Deputy Director, Larry Petrick, who will be joining us on the panel, and again, a very critical part of our health and safety team. And Amy Howard, who with CPF, our California Professional Firefighters Association, the legislative director there, just thank all of you for being here at this workshop. And I'm going to be very, very brief. It's shocking out there, I know. But this is really a critical and serious subject that we'll be dealing with this morning. The fact of the matter is that last September, when we gathered in Colorado Springs, we put 168 names on those granite walls. And 100 of those names were LODD from cancer. More than ever, we know that our local leadership needs to be involved in the process of standard operating procedures and establishing procedures in order to safeguard our members. We know it's imperative that you help and we help to protect our members from exposure to dangerous carcinogens and implementing the SOPs that are going to help keep them healthy and extend their lives. This workshop is going to address the awareness issue and prevention issues, and it's here to educate all of us on the exposure hazards from diesel exhaust, contaminants at the fire scenes, and the things you can do right now to go back home and to help to lower the risk of those of our rank and file from developing cancer. We're going to equip you with the tools necessary to effect personal commitment and organizational accountability, including annual medicals as outlined in our Wellness Fitness Initiative, which we will be releasing the 5th edition very soon, and also to discuss early detection and treatment and how to minimize the contraction of these deadly cancer diseases. We've been doing good work across both countries to provide protection through our presumption laws, which is critically important. But what's really important is the work that we're going to be doing and continue to build on so that we don't have to depend on those laws and we don't have to place more names on those walls. So I welcome everybody to our workshop out there through the internet and across the United States and Canada. And I'll be here to listen to these presentations and come back at the end when we're finished with our work this morning. But right now, I'll turn it over, Jim, to you.
Thank you, Mr. General President. As the Director of Health and Safety, part of my charge is to look at occupational diseases, the research out there, and find ways to minimize the risk to you out there in the field. And as a member of the IAFF, 22 years with Prince George's County Firefighters, Local 1619, 14 years on the Executive Board, Chair of the Health and Safety Committee, and 2 terms as our local union president, I know the challenges you are facing. I know the tools and information that you need. And I think what we've done today is assemble a panel that will help give you some key takeaways where you can start affecting change as soon as you get back to your home departments. So we're going to discuss the science that's out there and how you can use that to your advantage to minimize risk, what you can do when you go home so your members can help prevent these horrific diseases. And then we'll talk about some legislative efforts that you can use, tactics that we know have worked in the past that maybe you can use in your local to affect some change. At the end of our session, we will have a question and answer period. I ask that you hold all of those questions until that time. And the participating audience here in the room, when we get to the question and answers, I ask that you go to the microphone and identify yourself and then state your question, and someone from the panel will address that. So with that, let's get right into it. Our first speaker is going to be Dr. Virginia Weaver. She's an associate professor at the Johns Hopkins University, Bloomberg School of Public Health, with a joint appointment in the School of Medicine. She received her medical degree from New York University and her master's in public health from Johns Hopkins. She is dual boarded in internal medicine and preventive occupational medicine. She has been on the faculty at Johns Hopkins since completing her occupational medical residency and postdoctoral research fellowship there in 1993. She's directed the occupational environmental medical residency at Johns Hopkins from 2006 until 2014. Dr. Weaver focuses on firefighter cancer and workers' compensation issues in her public health practices. She has given numerous national and international presentations on cancer and firefighters and is the author on more than 80 peer-reviewed articles, chapters, and abstracts. She's been a member of the IAFF Medical Advisory Board since 1995, and she has served as the medical preceptor for the Residence Physicians Program at the IAFF for more than a decade. Please join me in welcoming Dr. Virginia Weaver.
Good morning, and thank you so much for that kind welcome. I would like to thank the General President. I would like to thank Pat Morrison and Jim Brinkley for the kind invitation to be here today to talk about a topic that is so important. So I'm going to focus for the next 45 minutes on the research that connects cancer risk in firefighters. I'm going to discuss with you one of the standard studies that we used for many years, the LeMaster study, and then I'm going to discuss some of the more recent studies that have come out in the last couple of years, because this area has become very important and a very relevant topic, particularly recently. So we'll talk about what the research shows us. I'm then going to focus on what we can do. What should be the response? Because it's not enough just to know that there's an increased risk, but then we want to determine what proactive steps can be taken in response. So we'll talk about cancer screening, and we'll talk about primary prevention from a non-occupational perspective. My colleague Larry Petrick will talk about the occupational primary prevention approaches. And then finally, I'll finish up with just a couple slides on the medical basis for why presumptive legislation for cancer is so relevant and so important. So let's start by talking about the types of research that can be done to determine if, in fact, the exposures that you all have in your day-to-day jobs increase risk for cancer. Now, my co-panelists, Larry Petrick and Amy Howard, are going to talk in more detail about the components of smoke and diesel exhaust and flame retardants, which really set the stage for why we would even do research to look for an increased risk for cancer in the first place. Based on that exposure information, it's clear that such research does need to be done. So how do we go about doing it? Well, first, we need to keep in mind that cancer is extraordinarily common. It's the second leading cause of death in the United States after heart disease. So that means that if you personally are not a cancer survivor, you will clearly have known someone who is. It's just that common. The next important thing we need to keep in mind is that there are many, many risk factors that have been identified that increase the chances that someone will develop cancer. So we all know about smoking. Many of us know about diet, genetics, family history, and then a range of work and non-work or environmental exposures. So those need to be considered as we look at risk. And a final challenge is that cancer takes years to develop. So in contrast to when you have an injury in the midst of fighting a fire and it's very clear that that injury is work-related, it is much, much trickier for cancer, which is going to develop years after the start of the exposure. That's called latency. So what kind of research can we use to sort this out? We can use animal studies. You can expose rats or mice to chemicals that are commonly found in smoke or in diesel exhaust, and you can see if those animals that are exposed have an increased risk for cancer compared to animals that are not exposed. That's a bit tricky because animals are not humans. So when possible, we like to look at human studies. Now, obviously, you can't take a group of humans and say, you're going to go become a firefighter, or you're going to be exposed to benzene or whatever, and you're not. So we're left with a technique called epidemiology, which tries as much as possible to compare those who are exposed with those who are not exposed, while taking into account other differences in the population. So for example, firefighters can be studied, and their rates of different types of cancer can be examined based on death certificates or cancer registries. All right? And you compare those rates with members of the general public who have never served as firefighters, or with groups of firefighters whose exposures are thought to be lower. Another type of study in humans that can be conducted is called a case control, where you look at populations who have a certain type of cancer and you go back and ask them, what did you do for a living? What kind of exposures do you have? And you see if those exposures are similar to firefighters or if in fact they had a higher risk of working as a firefighter. So then, what's the common sense or the science behind the findings? Well, first and most important, there needs to be sufficient latency or passage of time. So most solid tumors take 10, 15, 20 years to develop after exposure first starts. Liquid tumors like leukemia, they can start much earlier, 3 years or so. All right, so latency is important. Then there's a whole series of biological plausibility aspects that depend upon exposure. That's the challenge for firefighters. Why is that a challenge for firefighters? Just the smoke from cigarettes has now been linked with all those different types of cancers, most recently colorectal and liver. So if smoke from just a cigarette can cause that many different types of cancers. Imagine how much is in smoke in firefighters based on car fires, house fires, industrial fires, dumpster fires. Think about the range of exposures. So exposure is a huge challenge in these studies, and we'll come back to that. Let's first talk about what the recent research shows, starting with the Lemasters meta-analysis. So what is a meta-analysis? It takes a variety of earlier studies and combines the data. Why do you want to do that? If you have tiny studies with just a few people with a particular type of cancer, you can't tell if their risk is increased because the numbers are just too small. Our science, our statistics don't allow us to detect. But if you put those studies together and instead of having 5 people with prostate cancer, you have 500 with prostate cancer, then you can statistically say, yes, there is an increased risk, okay? Very powerful, very important, this approach. The disadvantages are that if the data in the studies or the studies themselves are not of high quality or consistent, then you may not be able to get results that are meaningful. Okay, so the quality of the studies is very important, and fortunately we have a number of recent studies that are very high quality. The Lemasters study, which came out a decade ago now almost, was in fact a meta-analysis, and they combined 32 earlier studies on risks for 20 different cancers in firefighters. And amazingly, they found the risk was increased for 10 of those 20 cancers. That's 50%. That's striking. Of the other 10 they looked at, risk was increased, but not statistically. Okay, so that's kind of a wake-up call. Based on that, the National Institute for Occupational Safety and Health has completed or is close to completing what is one of the largest, if not the largest, study of U.S. firefighters going back decades. So this is what we call a historical cohort, meaning that the study conducted over the last 4 years looked back 60 years. Looked at firefighters in Chicago, Philadelphia, and San Francisco and went back to their employment records to see when they were exposed, how long they worked as firefighters, et cetera. And they were able to study almost 30,000 firefighters, which is a huge number. And because it was such a large number, they were able to get some data on non-white firefighters and female firefighters. Those are much smaller numbers and harder to get good data on. They have a website, which I've listed here, that they use to disseminate information about the study over the 4 years they've been working on it. Phase 1 of the study was published in 2013, and that study compared rates of cancer, both incidence, which means cancer diagnosis, and mortality or death, in firefighters compared to the general public. And they were able to control for things that are known to impact risk of cancer, like age, sex, race, and time that the individual calendar time of diagnosis. So this is a big study. Look at that. That's almost 5,000 cancer diagnoses that can be used for incident data and more than 3,000 deaths. And importantly, they found an increased rate of just all cancer overall, both for diagnosis and for death. And they found significant increases in certain cancers, both for diagnosis and for death, specifically esophageal cancer, the feeding tube that goes into the stomach, the large intestine or colon, the oral cavity, meaning the mouth and the back of the throat, the kidney, lung, which I was actually happy to see because you breathe in a ton of lung carcinogens, and lung cancer should be at increased risk in firefighters, and a fairly uncommon cancer called mesothelioma, which is cancer of the linings around the lung or the abdominal cavity from asbestos. So that makes sense as well. They found some other risks that were present either just for diagnosis, incidence, so that's laryngeal cancer below the back of the throat, and in specific age groups, bladder and prostate, and for mortality only, rectal cancer, the liver, gallbladder, bile duct group, and in older firefighters, non-Hodgkin's lymphoma and stomach. So this is a complex, huge study, looked at lots and lots of different data, very important. They're now finishing up phase 2. Phase 2 is to try and compare firefighters across the range of exposure, okay? So this is to be able to compare the most exposed firefighters with the least exposed firefighters internally. This is much, much trickier. It's great when you can get it to work, but remember I said exposure is the huge challenge for firefighters. So they tried to look at number of fire runs over the working lifetime for each firefighter. How many times did they go to a fire? How many days were they exposed? And then the best metric, how many hours did they actually spend at each fire to get a fire run estimate? They're trying to include information on use of personal protective equipment because that's changed over the years. Whenever I talk to older firefighters, when I'm out testifying for presumptive legislation, the older guys will say, you know what? It was not cool to wear SCBA when I first joined the service. We just didn't do it. And then, you have the middle-aged firefighters who say, well, we did it, but not for overhaul because, that really limited our ability to tell if there was a risk of reignition. So, we couldn't do our job. And then our latest emphasis we'll be talking more about is what else can you do other than SCBA? So, this has really changed, and so use of protective equipment is important. Use of diesel exhaust controls is also important. The results of phase 2 have been submitted to a journal for publication and they're being revised, so they're not available. We hope they'll be available very soon. Obviously, internal comparisons are great, but very, very challenging. So we'll look forward to the results of that study. There is a second study that I want to talk about that's very recently published, and this is the Nordic study that is done in 5 Scandinavian countries. Again, very long time frame from 1961 through 2005, but about half the number of firefighters in the NIOSH study. There are some commonalities, though. They also found an increased risk for all cancers combined. And for individual cancers, they found increased risks for melanoma and non-melanoma skin cancer, the more routine stuff that we think about. Also lung and also prostate. And in their older age groups, mesothelioma and multiple myeloma. So there's some consistency with the NIOSH study, which is good to see. Note that this Nordic study just looked at cancer diagnosis, did not look at death. There is a very hot off the press study from Australia, and I was very fortunate to run into Alex Forrest in the hall this morning who could give me a quick sound bite because this is a very large, complex study. But this looked at both cancer mortality and diagnosis or incidence in firefighters in Australia from 8 different agencies. Their number of full-time firefighters is similar to the Nordic study, but they also added in part-time firefighters and a huge number of volunteer firefighters. So that's the unique aspect of this study. They found that overall death from cancer was actually decreased. So that's a bit different from the prior 2 studies. However, diagnosis of cancer, that risk was increased for all cancers, for prostate, and for melanoma. Okay? So one of the challenges in this study is that there was a very strong effect called the healthy worker effect. Now, I'm going to tell you more about what that means in a couple minutes. But basically, if you looked at the career Australian firefighters, their risk of death compared to the general public was less, significantly less. These guys start out healthy and are staying healthy. So that makes research very tricky. It's a relatively short follow-up in this study, but moving forward, it will be a very rich source of data. This is a long report, 275 pages, so I haven't waded through all of it yet, but there's a lot more data. There's risk by age, by sex, and there's some exposure metrics in there as well. And I've listed the website for you if you want to see more. And then I want to talk about a study that came out of Korea that I originally didn't realize was relevant because it talked about professional emergency responders, which sounded kind of like EMS, but in fact 88% of their cohort worked as firefighters. So this is a big study, almost 30,000, although followed for a relatively short period of time. So we don't have a lot of cancer diagnoses yet. They did find some risks that were very similar to the NIOSH study: colorectal cancer, kidney and bladder, and non-Hodgkin's lymphoma. They tried to look at duration of exposure. Again, very tricky. Didn't find an increased risk with work as a firefighter more than 10 years, except for bladder cancer, which had such small numbers. For less than 10, it was really hard to say much about it. Many of these studies have similar limitations. Tiny numbers of individuals diagnosed with a particular cancer. The challenge is that risk for prostate cancer is not the same as risk factors for breast cancer, is not the same as risk factors for colon cancer. So you can't just lump them all together, and so it makes numbers very tricky. Limited data on exposure and other cancer risk factors, and relatively short follow-up. Now let's talk a little bit about those risk factors in more detail. What effect do they have on the research? We'll talk about exposure misclassification, healthy worker, small study sizes, and data on other cancer risk factors. For exposure misclassification, a lot of the research has just basically used death certificate. Were you ever employed as a firefighter? Was that the last job you ever held, the longest job you ever held? And so if you think about all the different components in smoke, and you compare that to all the effects we see from cigarettes, it gives you a sense of how very challenging this is. And in fact, the International Agency for Research on Cancer, which Larry is going to talk about in a minute, has actually looked at firefighting, and they've said it's possibly carcinogenic. We can't say more than that, and one of the big reasons is because exposure assessment is such a challenge. All right? I think the NIOSH study is about as good as we're going to get at any point, at this point, until we maybe reach the phase where we have, exposure monitoring everywhere we are through cell phones, or, very advanced technology that's kind of being discussed now but is not there yet. The healthy worker effect. Firefighters enter the workforce much healthier than the rest of us, and they need to stay healthy in order to do work that is so incredibly physically demanding. However, it is that effort to stay healthy that actually reduces their risk for many diseases, including heart disease and cancer. So in the LeMaster's meta-analysis, firefighters had a 10% lower risk of dying from all causes at a given age than the general population. You saw it was a 30% lower risk in Australia. It's huge. What does that do? Well, it means that your risk actually has to be elevated above what we would consider a non-risk in order for it to show up at all. So it's really quite tricky. We've talked a bit about small studies. Firefighting is not an incredibly common occupation, and each cancer is different, so we have to look at them separately, and it makes power a real problem. Look at these sizes. The NIOSH study is in fact the largest by and large. You start dropping down when you look at the Nordic study, lower for Australian and Korea, and then it's a little less clear for the LeMaster study because the study includes lots of different study types. But it looks like the LeMasters had a lot more data on death rather than on diagnoses. Okay? What about data on other cancer risk factors? These studies, far and away, or for the vast majority, were not able to incorporate any data on common risk factors for cancer like smoking. So oftentimes the studies are criticized with the question, well, how do you know that the firefighters didn't just smoke more? How can you say that's from firefighting? We don't know about family history. It's not included in the studies. Not much on diet or other exposures. Cancer screening gets raised as an issue. Is prostate cancer really increased, or is it just because firefighters get cancer screening done? And the Nordic study specifically tried to answer that question by looking at risk for prostate cancer before and after screening was implemented in the countries involved and found that there did not seem to be a big increase just related to screening, suggesting that screening is not the explanation for the increased risk of prostate cancer in firefighters. What do those research hurdles or challenges do to the research question we're asking? All of them, with the exception of lack of data on other cancer risk factors, result in underestimation of risk, making it harder to tell if risk is truly increased. So firefighters' risk ratios look the same compared to the general population or are not statistically significant. Now, the research is often criticized because the risks aren't high enough. We know that those factors are involved, but I want to say just a word or two about exactly how high the risks really are. How many people in this room think that if you are a spouse and you've been married to a smoker for 30 years, your risk of getting lung cancer is not increased? No one. No one's raising their hand, okay? So we all think there's enough research at this point to know that if you're exposed to environmental tobacco smoke, you have an increased risk for lung cancer. What's the risk? About a 25% increased risk. That's very similar to what we're seeing in firefighter studies. So I think the idea that the effect size is too small and we can't say it's real is just not there. So what do we do with this information? What risks do we think actually are increased? And in the absence of some new meta-analysis, if you look at the data that I've shown to you, the cancers that I have listed here have been found to be an increased risk in at least 2 of the 3 studies, LeMaster's, NIOSH, and the Nordic study. The ones that I have underlined are the ones that were significant in all ages for both incidence and mortality when it was looked at. So those are the ones that we really have the most data for. You could add bladder and kidney in if the Korea study is also used. So that's clearly more than the sort of traditional cancer thinking of one chemical and one cancer. You know, we connect benzene and leukemia, for example. But if you think about the fact that smoke and diesel exhaust and flame retardants, it's not just one exposure, it makes much more sense. Now, what are the implications from this? What proactive steps can we take? Well, first, exposure prevention is absolutely critical, and we're moving beyond just SCBA. And so my co-panelists are going to talk to you in detail about this incredibly important aspect of prevention from occupational exposure. I'm going to focus a bit on cancer screening. We've just done a major update of that for the Wellness Fitness Initiative. I'm going to talk about cancer prevention for non-occupational risks. And I'm going to finish up with just a slide or two on presumption. All right? So, wellness fitness. The screening that is recommended starts with what authoritative agencies recommend for the general population. So we're looking at what does the American Cancer Society say that you should do? What about the U.S. Preventive Services Task Force? And then for the cardiac part of wellness fitness, we looked at American Heart Association as well. But that's not good enough because you're not members of the general population. You have unique occupational risks. So what we tried to do as an expert panel is modify the general population recommendations to reflect that increased risk. And I'll show you some examples for colon cancer and for breast cancer that reflect this thinking. So first, it's important to understand that there's not an acceptable screening tool for each and every cancer. Some of them simply have physical exam components. So when you have an annual exam as part of wellness fitness, your thyroid can be palpated to see if there's any nodules that could represent thyroid cancer. The healthcare provider can look in the mouth and see if there's any sign of cancer there. Do a skin exam for both melanoma and non-melanoma skin cancer. Examine the lymph nodes for lymphoma and do a breast exam. All right? The testicular exam is recommended in the baseline initial exam for wellness fitness, and then a self-exam is recommended thereafter. Testicular cancer was a very high risk in the LeMaster study, but has not been found to be as an increased risk in subsequent studies. Still important, though, to do screening to the extent possible. Lung cancer screening. This is a huge change. For years and years, when I first started in medicine, we thought, well, you know, maybe you can do a chest x-ray and maybe that will help detect lung cancer earlier. And at one point we thought sputum cytology. You can get folks to kind of cough up as much as they can from low in their lungs, and we'll look at it and see if we see atypical or potentially precancerous cells. Those things never really worked out, unfortunately, and lung cancer has a really poor 5-year survival rate, so you'd really like to catch it early. So a study that just came out looked at low-dose CT scans and found that in risk groups aged 55 through 80 who had smoked at least 30 packs of cigarettes over their lifetime, one pack a day for 30 years, okay, a 30-pack year history, and who either currently smoke or have quit within the past 15 years, they were actually able to reduce their lung cancer death risk, okay? So that's very important. That's something very different. Now, we need to see if that recommendation, this screening, the CT screening, can be used in other groups, particularly occupational risks, asbestos, radiation, firefighting. There's lots of questions about how widely this should be used, but clearly we're recommending it in wellness fitness for smoking. Cervical cancer, this was always my success example for cancer screening when it worked, the pap smear. It's been used for decades. It's fabulous. It's still used, but there's something new that can be used in combination with it, which is testing for the human papillomavirus, which is the cause of cervical cancer. So that's a bit of a change, is adding this in as well if the individual wants it. Breast cancer has been a bit controversial. Mammography was recently recommended to start at age 50 instead of age 40 by the U.S. Preventive Services Task Force. However, reflecting the American Cancer Society and our concern about risk in firefighters, the Wellness Fitness Initiative continues to recommend it starting at age 40, but every other year up through age 50. Okay, so that reflects differing risk levels. Colorectal screening. Again, differing risk levels. There's actually a few ways that you can detect colon cancer. You can look for blood in stool. That's called fecal occult blood testing. You can actually do techniques to look inside the colon, either with sigmoidoscopy or a colonoscopy, which looks farther up in the colon, to visually see evidence of cancer. And we felt, since the majority of the studies I've presented to you show an increased risk for colorectal cancer, that we should recommend firefighters start screening, have a discussion with their healthcare providers about whether they should start screening earlier at age 40. And if screening is chosen, we recommended using fecal occult blood testing just because it's very low risk. It'll pick up cancer, but the risk of having a colon perforation or something that can potentially happen with colonoscopy is not present. All right? Prostate cancer. More is not always more. And this has been a huge challenge. Because the reality is that prostate cancer is extraordinarily common. And so if you do autopsies on 80-year-old men who die of a whole range of causes having nothing to do with prostate cancer, you will often find little incidental tumors in their prostates that never spread, that never did anything to them. So the challenge for us is to figure out which tumors in a much younger person are going to spread and which are going to just stay there and not do anything. And we thought prostate-specific antigen could do that, PSA testing. But it's really shown that it just doesn't do a good job of it, and it leads to a lot of surgery that has significant morbidity. Okay, so you've got a real risk-benefit ratio problem there. Now, this is an extraordinarily controversial discussion, because if you talk to someone who's had their prostate cancer picked up by PSA, they will say, I'm alive today because of it. But if you talk to someone who's had a bad outcome from their prostate surgery, then, you'd really like to know whether it was necessary or not. So the change that we've put into wellness fitness is to have a discussion with your healthcare provider about the pros and cons and about what your individual risk level is. There are some other cancers that do not have a good screening test. Brain cancer is one of them. We really don't have a way to screen for brain cancer. Leukemia, similarly. So we would like screening tests that work, that identify early on when someone has a precancerous stage that can be treated successfully so that they can then be a cancer survivor. We don't have that yet. We would like to be able to focus our screening so that we know who is at risk and can get that screening at increased levels for those individuals. So this is still a goal. I've put a few screening resources for you here. The Wellness Fitness Initiative is in the online library under Health and Safety on the IAFF's website. We are in the process of optimizing, updating this, as I said. And then I've listed the websites for you for the two organizations that are most widely followed in terms of screening recommendations. You'll notice the Cancer Society actually has what they call guidelines for the early detection of cancer. Okay. Cancer prevention. You know what? It turns out your mom really was right. An ounce of prevention really does equal a pound of cure. So you can do lots of cancer screening, and we're doing a better job now about about good cancer treatment that works, increasing 5-year survival, but the best approach is proactively to prevent cancer in the first place. So the most tried and true statement in that regard is do not smoke. We've made progress. We actually have lowered smoking rates in the U.S., but we're not there yet. There's still way too many people who start smoking when they're young and get really addicted. The good news is that we have way more options for smoking cessation than we ever used to have before, and so that's the message I want to give you about smoking, is that for those individuals who unfortunately are smokers, not only do we have nicotine substitutes, we have a number of medications that can help to deal with the addictive aspects of it. We have behavioral therapy options, so there's now lots of options to reduce smoking. And the smoking issue applies to chewing tobacco as well, because that also increases oral cancer risk. Diet is incredibly important, and the entire U.S. is pushing against us on diet because the diets in the U.S. are getting worse and worse. Many of you may be aware about the food pyramid. So the things that are on the bottom are going to be whole grains, then fruits and vegetables. You're going to have red meats, fatty foods, fried foods way at the top, being as little of those, really limiting your consumption of those. You want to avoid calorie-dense, nutrient-poor foods. What does that mean? Most of the fast food that we eat has lots and lots of calories, but not a whole lot of vitamins, not a whole lot of fiber, not anywhere near what we could get from having a less processed diet. And then something I also don't think gets enough attention with diet is portion control. You know, if you ever go to museums that show antique furniture and antique plates, the plates back 100 years ago were these little tiny dinky things, okay? Those people weren't eating anywhere near as much. And there's a researcher at Cornell who has looked at what the size of the plates and cups do to make us think about how much we've eaten. So if you put the same portion on a great big plate, you'll eat it and say, I'm full, I'm all set, I'm feeling great. But if you put, let me back up, I'm saying it the wrong way. If you put a portion on a small plate and it looks like you filled up the whole plate, You'll eat it, you'll say, yep, I've had enough, I'm doing great. But if you put that same portion on a great big plate, it looks like, wow, I'm not getting much here at all. And you don't feel as satisfied. So there are lots of cues about diet that don't just have to do with the food. Exercise, very, very important. I know a number of fire departments have options for exercising at work as part of work. A lot of us don't have that option, and so there's something called lifestyle exercise, meaning that you fit in as much exercise as you can just in your day-to-day activities. So I take the stairs. I try to avoid the elevators whenever possible. And I was delighted in the stairwell today. The stairwells are crowded in the hotel. You all are taking the stairs too. Usually I'm there by myself, coming to a door that's locked and I can't get out of the stairwell. So it's great to have lots of folks in the stairs with me. Other examples of lifestyle exercise, parking, at the edge of the lot and walking to your destination. Just fitting in everything you can, standing instead of sitting, etc. Weight control, very important, incredibly hard to do with our diet and our limited options for exercise. Alcohol in moderation, and if you think about it, it's really everything in moderation. I think that's a key. A lot of times we feel kind of whipsawed by different research coming out saying, margarine is better than butter. No, butter is actually still okay. I don't think you need to do absolutely one thing or the other. I think moderation, sunscreen, etc. And then lastly, let's talk a little bit about presumptive legislation. I think it's really important. It's present now in more than 30 US states and Canadian provinces and in Australia. What does it do? The reason it's so controversial is because a lot of people don't actually understand what it does. It removes the burden for the proof of causation from the affected firefighter. If you have cancer and you're getting chemo and you can't work and you have a family to support and you have bills to pay, the last thing you need to do is try and find some experts who can help make the work-relatedness for your case. But that's what's required under workers' comp, okay? Presumptive legislation just shifts the burden and it says, the employer with the deep pockets can sort out whether or not it's work-related. It does not guarantee that every firefighter who develops cancer is going to be covered by workers' comp. But it allows individual factors to be considered. Keep in mind that smoking is a very important risk factor, exposure duration. And the estimates are that the majority of cancer is not work-related. 4 to 10% gets thrown about, but those rates are higher in exposed populations such as firefighters. And the union can be of assistance in presumptive legislation. We can provide documents on science, documents on cost. Then for individual workers' compensation, the burden of proof legally is 51% rather than the 95% used in the scientific studies that I've just reviewed with you. But individual causation is complex. There are very few physicians like me who are trained to weigh individual risk factors. And so that's why presumptive legislation makes the employer scurry around and find competent people to actually think about it, as opposed to just denying it. And the IAFF can be of assistance here as well with documents summarizing what firefighters are actually exposed to and the science on their risk for specific cancers from their occupational exposures. So that summarizes what I had to talk to you about today, and then we'll have questions at the end, and thank you very much.
I think what I really appreciate about Dr. Weaver and her work is not just the ability to take a very complex issue and turn it into valuable, useful information for our members, but it's also the passion in which she does that. And she's worked with us for over a decade and has done a fantastic job, so thank you for that. Our next presenter is going to be Larry Petrick, Jr. He is the Deputy Director for the IAFF Department of Health and Safety. He retired after 33 years with the Shaker Heights Fire Department, Local 516. He was the Director of their Health, Safety, and EMS for the Ohio Association of Professional Firefighters for 20 years, served 11 years on their Fire and Police Pension Board, and he holds a bachelor's degree in Fire and Safety Engineering Technology with the University of Cincinnati. And more importantly, he's been a valuable addition to the IAFF Health and Safety team. Please join me in welcoming Larry Petrick.
Thank you. What Dr. Weaver covered is the risk, the increased risk that as firefighters that we have with the cancer. What I'm going to try to go over is why we feel that these risks are there, how it is impacting our body, the fire environment that we work in. When we look at our body is made up of cells. And these cells have a lifespan. And inside each cell is a nucleus. And that nucleus is the command center for the function of that cell. And inside that nucleus is DNA. And DNA is the blueprint of the function for that cell. If somewhere, somehow, that DNA is altered or damaged, it creates abnormal cells. And what happens is these abnormal cells are now uncontrollably. They uncontrollably grow and or they can uncontrollably spread and divide. And that is what's commonly known as a tumor. Now, when you look at tumors, there are basically two types that you hear about. You hear about a benign tumor. Benign is not cancerous. And what they are is tumor cells that grow locally and they cannot spread. But they can impact the body. If they grow large enough, they can impact the internal organs, they can impact blood flow, they can impact muscle movement. Then you have malignant. The malignant is cancerous. These cells invade the neighboring tissues, they enter blood vessels, and they spread. And that is known as metastasis. They metastasize, as you hear that term before. That means they move to different sites of the body. So sometimes a person can have a lung cancer, and then later on find out they have a stomach cancer or a brain cancer. Now, this is a process known as carcinogenesis. And in this carcinogenesis process, there's three phases. And one is the initiation phase, that something has to occur, something has to impact that cell. It has to alter it or damage it. So it enters the body and it covers that cell up. Number two process is it has to be promoted. And promotion can be either from the same initiator that entered the body that went onto that cell, or it can be something else. It could be whether another factor, another initiator that entered the body. It could be an internal factor, such as genetics, or it can be a lifestyle, as Dr. Weaver talked about, smoking, alcohol intake, drugs. Those things can impact and promote that initiator. Once that initiator starts to go into the promotion stage, or in other words, it starts now affecting the DNA, it starts to spread and grow, and that's known as the progression phase. Now, from the time that abnormal cell starts to grow and spread until the time that it gets discovered is what's known as the latency period that you hear about. Overall, cancer is basically a generic term for multiple types of cancer, but they really fall into 5 categories. And you've heard of melanoma, which is your skin cancers, carcinomas, with cancers of the tissues and internal organs, sarcomas, tissues of the bone, cartridges, muscles, connecting tissues, leukemia, which is of the blood and the cells that produce the blood, and then your lymphomas and myelomas, which impact the immune system. So what are these initiators? What causes the cancer? And really we can group those into two groups. One are internal factors and the other external. Now the internal is simply hormonal imbalance. It could be inherited mutations. It could be genetics. It could be immune conditions. The external factors are also known as carcinogens. Now it's important to realize, in the fire environment, there's a lot of toxins out there. It's a mixed bowl of soup of all kinds of stuff. But not all toxins are carcinogens. But they do, in fact, can impact the body and infect the body. But what we're going to talk about here today is the carcinogens that are out there. And really the carcinogens fall into 3 groups, 3 types. The chemicals, obviously solid, gas, liquids, viruses, hepatitis B, hepatitis C, chronic hepatitis B, hepatitis C are considered carcinogens. And then we have our radiation, which we all know, time, distance shielding, whether it's from radiological accidents, whether it's from warfare, biological, chemical, radiological warfare, whether it's from X-rays, research labs, or most commonly, the ultraviolet radiation from the sun. As you look at carcinogens, what is a carcinogen and who identifies it? Well, starting off, there's a lot of agencies throughout the United States and throughout all the countries of the world that analyze carcinogens, and whether a toxin or whether a chemical is carcinogenic or not. Now, each agency may have a different mission, and according to their mission, may decide whether something is that hazardous to be labeled as carcinogenic or not. So what may be carcinogenic for one agency may not for another agency, or what may be carcinogenic in one country may not necessarily be in another country. But let's take a look at some of this. You have NIOSH, and NIOSH obviously conducts the research and makes recommendations for OSHA. And NIOSH also maintains a database, the Registry of Toxic Effects on Chemical Substances, RTEX, which they call. And then OSHA, of course, through that research, will list some items that are carcinogenic in the workplace, because that's what OSHA does. They develop and enforce the standards for the health and safety of workers. We also have called the Agency for Toxic Substances and Diseases, and that's operated out of the United States Department of Health and Human Services. And also out of that department is called the National Toxicology Program. And they too do research on potentially toxic and carcinogenic chemicals in the country. But they're also, more importantly, they're the world's leader in designing, conducting, and interpreting animal assays. And that is the animal research and experiments in determining carcinogenity. And what's important for them is they do prepare an annual report on chemicals to the Congress each year from their research from animals. We also have the EPA that you hear about, and we know what the Environmental Protection Agency, and their concern is regulating chemicals in the environment, not only to protect human life, but also the natural resources. So each of those can list something as carcinogenic. And that pertinent information, whether it's from these agencies or from agencies from around the country, is important, because what you have is the International Agency for Research on Cancer. That's the granddaddy of them all. That's the gold standard in determining whether something is carcinogenic or not. And when they list something as carcinogenic, it's non-debatable. That's what it's determined to be. But for them to rank something as carcinogenic, they need to do a lot. There's got to be human studies, there has to be animal studies, and there has to be a lot of pertinent information. And a lot of that pertinent information and studies come out of agencies like OSHA, the EPA, NTP, or other agencies that look at things and determine if something is carcinogenic in the workplace or in the environment. Now, the IRC classifies, there's 5 classifications. The first is Group 1, carcinogenic. And that is there's sufficient evidence across the board that something is carcinogenic to humans. There's no doubt about that. The second one is Group 2A, probably carcinogenic. Well, what is probably? Probably is likely to occur. There's limited evidence to humans, but there's sufficient evidence in animals to determine that this is probably carcinogenic. The next one is Group 2B, possibly. Possibly meaning, well, it may not be carcinogenic. And here there's really 2 ways how they look at that. One, that there may be limited evidence on humans, but absence of sufficient evidence on animals. Or there may be sufficient evidence for animals, but inadequate studies on humans. So they list it as possibly carcinogenic. The third class is Group 3, which is not classified at all. There's not enough evidence to even classify the chemical that they're studying and researching. And the last one, Group 4, is probably not carcinogenic to humans, where there is sufficient evidence across the board that that particular chemical is not carcinogenic. Well, what's this come down to? On this list, what we want to look at and discuss today is what we commonly see in the fire environment, and actually in our working environment, and the studies that have come out that's showing what is this toxic soup that we face every time we fight a fire. And on this list are Group 1 agents. We said Group 1 are the carcinogenics. You look at arsenic. Arsenic was basically in pressure-treated wood. It's in electronic devices, and you probably still see it in wood chips. So those pressure-treated wood's still out there. Asbestos, we know about asbestos. We hear about asbestos. Insulation in building materials, old vinyl tiles, pipe wrapping. Asbestos occurs in these old buildings that we have. Benzene. Benzene is a very, very big one, and you're going to hear a lot about benzene. And very simply, benzene is simply products of combustion. And I don't think that needs to be explained any further. Then there's benzoapyrene, and this is a type of a polycyclic aromatic hydrocarbon called a PAH. And you'll hear a little bit more about this PAHs. But again, this is formed by the incomplete combustion of any organic material, which is listed as carcinogenic. 1,3-butadiene. This is from rubber products, from paints, carpet backing. So you can see now we're getting into the household products that are in existence. Formaldehyde. Those are adhesives and binders for wood products, pulp, paper, glass wool, rock wool. It's also used in the formation and production of plastics and in textile finishings. Dioxins, again, it's an industrial process, but also incomplete combustion. Soot, I think that's common sense. We know what soot is. PCBs, they have been banned, but they still might be in existence, or from our firefighters that fought those years, PCBs in the past. Diesel engine exhaust. Diesel engine exhaust has a lot of benzene, a lot of formaldehyde in it. Vinyl chloride. Vinyl chloride is in plastics, PCV pipe, furnishings, packaging, decorative materials. We know our homes today is all synthetic materials. And it's getting less and less natural materials out there. And of course, on the EMS side, we talk about chronic hepatitis B and C. So you can see in a normal room fire, there's a lot of stuff that's carcinogenic in there. Group 2A, obviously is creosote for the formation from burning products, and the wood combustion byproducts, which we call the biomass fuel. And really, even though this one, 2A, with the wood combustion byproducts, and that's really more important for our wildland firefighters. And you think they're out in the open, but they're actually exposed to more smoke technically than really what we face in our lifetime. And actually that burning of all that natural stuff is carcinogenic because it creates a lot of formaldehyde in that incomplete combustion that's out there. Now you heard Dr. Weaver talk earlier about talking about the occupation of firefighting and IAFF listing it as possibly carcinogenic. And that's true. And what they did is they looked at that in 2010. And that year is important. And what they said, yes, we understand that you're exposed to a lot of benzene. We understand you're exposed to a lot of formaldehyde. And you understand you're exposed to a lot of 1,3-butadiene. And we understand that obviously the very nature of your job is exposing you to these carcinogens. But they feel there wasn't enough evidence to determine what is actually that exposure. How does it enter your body? What is happening that we can say that the very nature of the job occupation of firefighting is carcinogenic in itself? Well, since that time, there's been few studies, and we're going to take a look at and give you a little just a summary of those studies. Now, these two we'll talk about in a little bit, but really since that time, out of Oregon. In Oregon, what they did is they took a look at the overhaul stage. And out of the state of Oregon, what they found out, obviously, in the overhaul stage, there was arsenic, there's mercury, there's benzene, formaldehyde. These are all found in that overhaul stage. And it was actually the first study to say, you know what? We should stop the practice that it just naturally grew into, which is, okay, if we're taking off our air mask, maybe let's put on an N95 respirator. Let's throw a fan in. Let's air out the structure, the room. To go with a carbon monoxide detector. When the carbon monoxide detector is low, then we can go in and do our work and overhaul in that phase. And that's showing, and even in an overhaul phase, there still are a lot of gases still present, and that SCBA should be worn during that process. The University of Arizona did some studies, and they came up with, there's obviously aldehydes, the PAHs, and what they found out is when they, instead of having the N95 mask, they were using the half mask with the cartridges on there. And those are there to protect particulates. But what they found out is that the formaldehydes, it's not protection against the vapors and the gases. So the formaldehydes were coming through the cartridge, penetrating the cartridge and penetrating the air purifying respirator cartridges, the P100 cartridges. Now, though that was a smaller study, it did raise a lot of concern that, again, these type of things that we feel, okay, that's helping us in the overhaul stage is really not, that we're still putting ourselves at a hazardous risk at that time. NIOSH did a bunch of what they called health hazard evaluations. They did one on vehicle fires. And of course, testing the smoke from vehicle fires, and what they determined, yes, there was a lot of formaldehyde in there. They did a health hazard evaluation on smoke simulants, and a lot of mineral oil, formaldehyde, diethylene glycol. So again, you're seeing these common names in these type of fires. They did the thermal exposure to PAHs and benzene, which we're going to talk about in a little bit here, and which ended up as a study. The health hazard evaluation was looked at and it was put in as a study for a peer review, and it was published in a journal. So when something becomes a study, it carries more weight, and hopefully IARC will take a look at those things in the future. And of course, we're going to talk about this UL study, the firefighter exposure to smoke particulates. There was another study out of Ontario from the McMaster University, which is training fires that they've done and exposures in there. And I guess you're going to guess what I'm going to say: formaldehyde, benzene, PAHs, obviously carbon monoxide, dioxide, ultrafine particles. They're realizing now there are fine particles out there that you can't see from the naked eye that we think is clear air, but they're not. The microns are so small, they're in existence. And then we're inhaling them. But also, this was one of the first studies where they took a look at, after they fought the fires, they start taking urine samples. And then through the urine samples, they're finding out, the body is somehow absorbing or somehow intaking these carcinogens, and the body naturally always tries to cleanse itself out, and obviously through the urine, through our breath, or through the urine, and to come up with studies that saying, okay, the body is trying to clean itself out. Somehow something is getting into our bodies. And then out of Australia, Queensland, did a lot of studies on exposure to airborne contaminants. They did liquid petroleum gas fires, but more importantly, they did office fires, and they also did household contents fire, household room fire. And of course, the PAHs were high, benzo A pyrene we talked about, your volatile organic compounds, your benzenes, your formaldehydes, and obviously your hydrogen chlorides, hydrogen cyanide, carbon monoxide, all in existence there. But what was interesting out of here is as they came up and determined that it's not just existence in the environment, but now it's the turnout gear. The stuff is staying on the turnout gear. And obviously we see that with soot, but it's determined that there was a film of some of these chemicals. And those small particulates that we can't see are on our turnout gear and in existence. And what is that doing to our health when we take it off? And they also determined that it was make a determination of checking the skin after these simulated fires, and found out that there is evidence of these chemicals coming through our turnout gear onto the skin. Now, granted, the outside of the turnout gear protected a majority of the stuff, but they did find some evidence of the benzene and PAHs within. And obviously the big areas are the neck because of the hoods, but they found it in the arms and legs. So as we know, our turnout gear is porous, the material, and when you're in a fire and structure, we know that that's pressurized smoke until it gets ventilated out. But that pressure is pressing against there, coming through the gear and possibly going through the moisture barrier, and particularly in the areas where they get worn out, like the elbows and the knees and the legs. But they also took a look at it. It also could be entering in those areas what they call like a bellows effect. So in essence, when you're bending down, you're squeezing all the air out. But when you start moving around, it creates like a negative pressure and bringing that smoke within those open areas of our turnout gear. We have that open area between our bunker pant and our coat. And the less protected areas, obviously, around the wrist and around the boot pant leg area. But let's take a look at and discuss some of these. The first one in the UL study. And obviously what they found out is what we already know, that smoke has asphyxiants in it, it has irritants in it, it has allergens in it, and it has carcinogens in it. And obviously, if we were in industry, the time-weighted averages far exceeded the toxic environment. And this study also found out that there was a lot of deposits are put on the gear. And what was interesting is in the overhaul section of this study, 99% of the smoke particles found were less than 1 micron. And when we talked about cartridges and N95 respirators, you know, they're designed to stop at 3 microns. So these ultrafine particles could be coming through. And also the fact, because they're so small, like we said, they can't be seen by the naked eye, that the clean air, what we think is clean air, is not clean air. You know, obviously, again, high exposure levels during fire growth and overhaul for benzene, formaldehyde, arsenic. Deposits on the gear, on the hood and the gloves can contain platelets, PHHs, lead, and mercury. Now, what's interesting about the platelets is that they feel that that can be an endocrine disruptor, which can be a reason why firefighters see a lot of prostate cancer. But that research has to continue on in there. But the hood and gloves contain those same deposits, but the gloves had 100 times more of those chemicals than the hoods. So we know that our hoods, you know, obviously the gloves were going through the suit and stuff, and the gloves are picking that stuff up at 100 times more. And then we take our gloves off. You take this glove off, now you take your hand, take this off, now we wipe our face. You can see how we can contaminate ourselves with these chemicals. The NIOSH study. And this one too is they took a look at all the studies, and they were particularly interested in that Queensland Australian studies. And what they did is they're going to analyze as our body cleanses itself, it's through exhalation and breathing and through the urine. So they decided, okay, we're going to take firefighters, and they're not going to eat grilled foods. They're going to give a diet that's clean. They're not going to be at fire station. They're going to put them in clean clothes, clean turnout gear, and submit them to simulated fires and see what they come up with. And what they found was there was evidence of exposure to PAHs and benzene in their bodies. And there was internal evidence of the PAHs in benzene. And what they did is right after the fire, and what they did, the most they probably were in there was like 30 minutes. They went in, they knocked the fire down, they did overhaul with the SCBA on. They checked in and checked the SCBA afterwards to make sure there was no leaks, that it was working properly. And not only did they swab, but they took breathalyzer, and then over a period of time, and then they took urine test over a period of time, up to 3 hours. And what they have found, of course, is the benzene is entering our bodies. Now, when we talk about the initiators, and that's how we started off here, I was talking about initiators, something that enters our body and could attach itself to a cell. And it can stay there for a long time until something promotes it to cause it to progress. And these were just training fires, simulated fires, that this stuff was in there. And they had high levels of the PAHs on the neck. And when you look at our gear, what's probably now the weakest part is our hoods. So really, to put that in context very simply, is the PAHs and benzene entered the body even though PPE was properly worn in those controlled burns. Now, not only did it say that, but they also, like I said, the evidence showed there's a lot of the soot and those ultrafine particles are coming on our turnout gear. So obviously, we're taking off our mask, we take off our coat. Now we're rattling those things around, but we possibly could be inhaling them. We take our coat, we put it inside the cab of a rig, in which, of course, we'll be doing. There'll be a study conducted on what's inside our cabs. You know, the dirt, the dust that's in there. Are these PAHs, are these ultrafine particles in the cabs? Are they within the fire station? And are we possibly taking them home? Diesel exhaust, we know what we talked about diesel exhaust. And of course, the big thing, because that's the fire station environment. So we know the fire environment's bad, and we also know the diesel exhaust in the fire station environment. Do you have your door sealed off? Are you using exhaust systems? When you look at the cracks between the doors in the jambs, in the door frames, you see that black soot in there. It's not all necessarily dirt. It could be from the pressure from diesel exhaust coming through. So diesel exhaust is an issue because, like I said, it has really two of the big known carcinogens, benzene and formaldehyde. When we look at the carcinogens and what we just talked about, our environments, what are the routes of exposures? And obviously there's inhalation. And the first thing we think about is us as firefighters, what are SCBAs, are we inhaling it through our mouths? But what about the fire ground? Premature removal of the SCBA, the overhaul, which we talked about. What about the pump operator? Do we need to should we have a practice of having exhaust hoses to extend that exhaust? So depending on which way the wind's blowing, he's not standing there for hours taking in diesel exhaust. What about the exterior operating crews? Not wearing their SCBAs, just having them dangling there as they operate on the exterior. Poor fitting SCBA fit pieces. Are we properly doing what we're proper fit testing? In-station diesel exhaust exposure. And then when we talked about the doffing of the gear, those contaminants, as we take them off, are they entering our body? Skin absorption. And the skin absorption, as we talked about the studies there are some factors that need to think about. There's skin thickness, there's skin integrity, is there cuts to the skin. The location of the exposure, obviously the scrotum, groin area, under the arms, the neck, the jaw area, those are the forehead. Those all have thinner skin layers where thermal absorption can occur quicker. You got to look at the physical and chemical properties of the hazardous substances. Some are more easily absorbed than others. And even though that was a very short list, the carcinogen list is extremely long. And we can be exposed to a lot of those others, carcinogens that are out there from other types of fires that we fight. And obviously, the concentration of the chemical and how long and this is the key one, is how long those chemicals are remaining on the skin, the duration of the exposure. So the longer it's on our skin, it could be, as some of these studies are showing, they're entering our body. They're entering our body. Now, a lot of these studies were done after 2010, which goes back to IAFF, and we talked about possibly carcinogenic in 2010, and pertinent information, and that's hopefully they can take this information and prove it. But what can we do about it? Number one is our attitude has to change. The dirty gear has to stop. We can't be being proud of the dirtier my gear, the more experienced and tough firefighter that I am. The dirty apparatus cabs. We wash the outside. How often do we do the inside? Hey, we're firefighters. We know that they don't get cleaned as well as they should. Fire instructors and supervision. The attitudes there that this has to change. We can reduce risk by not wearing bunker gear, which got its term by having gear in our bunk rooms. We can't traps this stuff around, knowing that we have those PAHs that are out there. You look at the asbestos. Is the wrapping in our fire stations and our old stations all there? Are we ignoring it? Do we have areas where we can store our gear properly? And of course, using the diesel exhaust. At the fire scene, we talked about that. It's not just necessarily, you got to wear your SCBA there. You can't wear a respirator mask. You just can't air it out. Those 4 gas detectors are not picking up all the other gases that are out there. And we know they're ultrafine and they exist. Some departments have cut teams, cleanup teams. Just like you have RIT teams, they have cut teams. Because you're wearing your back, your shoulders are sore, your hips are sore. You don't want to put the air pack in an overhaul. So they have cut teams coming in and do the overhaul with the firefighters. NFPA 1851, you should all read that document. It's about cleaning our protective gear. And there's 3 types: routine cleaning, and it's cleaning the gear at the scene with a soft bristle brush. But obviously in the wintertime that can't be done, but we can brush it off. And maybe it's time to take our gear and our coats, and maybe we put them in a different compartment instead of putting them in the cab. But again, when the study comes out, it'll be interesting to see how much of this stuff is in the cab. Advanced cleaning is washing our gear in obviously extractors, and specialized cleaning going out and having gear sent out when it gets decontaminated. Now, the thing with NFPA, they make a difference between soiled and contaminated. Soiled being what we do in the fire scene, our gear gets dirty, and soiled, contaminated, meaning it's contaminated by a CBIRN or a hazardous type of material. You must take a shower. Guys can't take showers 2-3 hours later. Wash our hands constantly. And the other thing is the wet naps is becoming common, where at the scene, when you're doing a rehab, you're changing your SCBA, is get in there and start cleaning your neck area and your hands up because of the chemicals that we said earlier that are showing up on our skin and being absorbed. And as Dr. Weaver said, is lifestyles, we don't want these to be initiators or promoters. And again, you can see that don't chew or smoke, watch your weight, exercise, control weight, alcohol moderation, use sunscreen, the medical exam, and cancer screening. So what I hope here in conclusion is you understand, we understand we're at a higher risk, but now you understand why we're at a higher risk. And that this stuff is entering our body and it is becoming initiators. And it's time now to start doing things that are uncommon. Make sure we're cleaning our gear after fires. Those things are important to reduce the risk of this dermal risk that's entering our bodies at this time as we know it. So with that, Jim?
When we develop tools and resources for you, our affiliates, to service your members, we pay very close attention to the words we use, and we actually use this saying all the time that words matter. So you have to make them count when you're writing them, whether it's an oral presentation, video, or whatever we're doing. And I think if you really pay attention to some of the key words Larry used, any one of our members will tell you when they come out of a fire, they're dirty, that they have soot on them. But listen to what Larry said. He talked about being contaminated. He talked about having chemicals on your body. And that's what this really is. You're not just dirty. You're not just covered in soot. You're contaminated, and you need to be decontaminated properly. So really pay attention to some of the words we're using, and I think you'll see how this really makes sense. Now, in addition to all the preventative efforts that we've talked about, some of the things you can do after you're exposed, we also have a lot of legislative efforts that have been very effective in helping protect our members. To address this, we've asked Amy Howard to join us. She is the legislative director for the California Professional Firefighters. She has over 20 years of experience working in and around the California State Capitol. As a member of the CPFFF's governmental advocacy team, Amy has successfully worked on many of the critical public policy issues directly affecting California firefighters. These include making sure we have better protections through our presumptive legislation. The many victories include landmark legislation under cancer presumptive in spite of the historic budget cuts and the deficits in a devastated economy. Prior to joining CPF, Amy worked for the California Public Interest Research Group as a legislative coordinator and later became the organization's Prop 212 Northern California statewide initiative campaign fundraiser. It is these experiences that have ultimately shaped her multidimensional view of California's legislative and political landscape. A San Diego native, Amy is a graduate of CSU Sacramento and holds a bachelor's degree in government. Please join me in welcoming Amy Howard.
Thanks, Jim. Good morning. So I was hoping to take the latter part of today's panel discussion to share with you a few examples specific to the California experience that were directly built on so much of the science that you've heard about today, the medical evidence, the studies and the research, and then of course the personal experiences that come directly from our members and their families. Going backwards. There we go. So as Dr. Weaver mentioned earlier, some 30 states have cancer presumption laws protecting firefighters on the books now. California is one of the 30. We, in fact, were the first state in the nation to get a public safety cancer presumption statute on the books. The first iteration of the statute, however, was slightly different than what we have today. It included a sunset that, had it not been for legislation removing it in future years, would have meant that the presumption would have fallen off the books about 5 years or so after it was first enacted. And then the burden of proof at the time was actually on the firefighter, not the employer, to demonstrate occupational exposures that ultimately were associated with the cancer that the firefighter had. So as a result of those two variables, CPF launched the Personal Exposure Reporting Program. And the program provided benefits on two fronts. First, it allowed the organization to collect aggregated data on workplace exposures that in turn we used to make the case to indefinitely extend the cancer presumption in this state. And then secondly, on a more individualized basis, it helped the firefighter in the event that a claim for benefits was filed under workers' compensation and that claim was denied either by the employer, third-party administrator, et cetera. And some of you in this room are probably members of the PER. The program actually isn't isolated to only California firefighters. It's open to any firefighter, irrespective of rank, nationally and internationally. And if you're not a member and would like to find out more about the program, we've got some brochures here at the front table. Feel free to grab one on your way out. So fast forward to 1999, the organization actually achieved another major legislative victory when we were successful in enacting a bill that shifted the burden of proof from the firefighter to the employer, thereby creating what we call a rebuttable presumption in California. And that is the type of presumption we have today. A decade later, in memory of our former Secretary Treasurer, former OES Director, former LA County Firefighters President Dallas Jones, we were successful in extending the statute of limitations on filing a workers' comp cancer presumption claim post-retirement from 5 years to 10 years. And then just last year, under the leadership of CPF President Lou Paulson and our existing executive board, we were able to extend the time frame in which a survivor may file for death benefits claims in instances where their loved one succumbs to occupational cancer and a couple of other presumptive-related illnesses. I think it's important to note that the presumption that we have in the state is all-inclusive. The law in California doesn't discriminate between the different types of cancer. So regardless of the type of cancer contracted, it's presumed to be job-caused. The presumption affords full hospital, surgical, medical treatment, disability indemnity, and death benefits, as I mentioned earlier. And also, as I mentioned, because it is a rebuttable presumption and an employer can challenge it, it's imperative that the firefighter maintain an ability to demonstrate job-related exposures should the need arise. And finally, another important piece to the presumption is that unless it is controverted, then state law requires that the Workers' Comp Appeals Board find in accordance with the presumption. So cost considerations. This is probably the one question that we get asked more than any other, and that is, how much does the cancer presumption cost? And the reality is, good or bad, generally speaking, the data that specifically quantifies state and local survivor death benefit claims and related presumptive claims just doesn't exist in California. And that is due in large part to the fact that state and local governments just don't drill down and break out that kind of data to such a fine degree. As far as cancer presumption claims go, the best sort of estimate, if you will, that we do have is a review that was conducted a few years ago by the state's Division of Workers' Compensation. They looked at firefighter-specific cancer and cancer-related claims that were filed within the system between 2000 and the end of 2009, and within that decade arrived at an estimate of anywhere between 1.1% and 2.2% of all claims filed within the system were specific to cancer. And I think that's really important to note, that it was just 1.1 to 2.2, not this exorbitant hit to the system, which, if you've all worked on presumptive legislation in your own states, is one of the main arguments that employers use. On the survivor death benefit side, again, data by state and local agencies just doesn't drill down to that fine of a degree. However, I can tell you that when we were running the death benefits bill through the legislature last year, we did have fiscal committee staff attempt to arrive at some sort of a price tag, and in their efforts said that it may be fair to assume that for each accepted state survivor claim, an estimated $50,000 is added to that employer's workers' comp expenditures. Similarly, our state's Commission on Health and Safety and Workers' Compensation commissioned a study to look at the same issue and ultimately concluded that across all affected state agencies, it may be fair to assume that on the death benefit side, you're looking at anywhere between 3.2 and 3.8 million spread across all those agencies. Oh, and I think it's also important to note that the survivor death benefit in California is not just one particular lump sum amount. It varies from a low of $70,000 to $250,000, and the variable includes how many qualified dependents that survivor has. So when we talk about cancer presumption and survivor death benefits, I think we tend to look at it through a defensive lens. That is, here are safeguards that are in place in the event of. But switching lenses and looking on the offense and what is being done proactively on the public policy front to minimize firefighter cancer risk, two specific recent examples come to mind from here in California. And the first is Technical Bulletin 117/2013, and the second is State Senate Bill 1019. So California law requires that manufacturers who make upholstered furniture and bedding products in this state that are also sold here be flame retardant. And the old flammability standard that we had on the books in California, dating back to the 70s, that was modified and took effect January of 2014, didn't prescribe the use of flame retardant chemicals, manufacturing methods, or specific materials that were needed to meet the standard. Furniture manufacturers, however, chose to add copious amounts of chemicals to their products in order to meet the standard under the old structure. California was the only state to have established this kind of flammability standard, and because California supplies such a huge portion of the national market, manufacturers decided in growing numbers to just use what they needed to use to meet the TB 117, the old standard, in all of their products, regardless of whether or not they were sold here or not. So over the course of the last decade, in particular, concerns with TB 117, the old standard, increasingly grew. And this was in part due to a few factors. The first being that more and more research was done highlighting the fact that there were adverse environmental and health impacts being associated and or linked to the chemicals that these manufacturers were using to meet the standard. The second, research showing that these chemicals really weren't providing any added fire safety benefit, which was a core argument from industry back in the 70s when the old standard was first promulgated. And then finally, it became clear that adding these chemicals to furniture components like polyurethane foam, for example, was inefficient since the exterior material is typically what catches fire first. So given these realities, current governor, Governor Brown, directed his state regulators to take another look at the old standard, review it, and update it. And despite heavy pressure from industry over the course of about a 14-month period, in January of 2014, as I mentioned earlier, that new standard took effect. The same month, Chemtura filed a lawsuit against the state of California, challenging the standard and urging the court to overturn it. At that point, from a policy perspective, we began to ask ourselves, if the standard is able to be upheld, how will consumers know what that new standard translates into? And at that point, we decided to join with others in co-sponsoring a bill that required the disclosure of these flame retardant chemicals in products by manufacturers.
The afternoon of January 27th, 2011, I felt a strange twinge, which then became a narrowing of my vision as I was driving. I was able to pull my truck over What happened next, I would never expect in my life. I suffered a grand mal seizure. Ran up to Marin General Hospital for testing and determined that I had a brain tumor. They took out roughly half of a Cornish game hen of affected brain material. When I mentioned what I did for a living, the doctors were like, oh, okay, well that explains a lot, just based on the types of exposures that we receive at work.
Chemical flame retardants are actually found in a number of different household products, anywhere from upholstered furniture to children's products, electronics. So flame retardants can actually be found in a lot of what we would consider normal products in our house.
Flame retardant chemicals are associated with a number of health concerns, including cancer, decreased fertility, hyperactivity, lower IQ, and hormone disruption.
We know that when they burn, they convert to known carcinogens, furan and dioxin, and that's what is causing the great threat to the health of firefighters.
Your skin is the biggest organ in your body and the biggest entry point for everything. Yeah, it helps to wear full protective clothing, including breathing apparatus, but your skin still absorbs everything.
Chemical flame retardants do not provide meaningful fire safety benefit. They don't actually prolong any escape time from getting out of a fire, and we're actually, through various studies and the state's research, found to be harmful to first responders and anyone else who might be in the room when a fire started.
At a time, many decades ago, it was helpful, and I think science has now suggested that there's other better ways to deal with it rather than these chemical protectants.
Senator Mark Leno's bill on disclosure of flame retardant chemicals is a right-to-know bill.
This bill does not ban any chemical. It's simply a disclosure, consumers' right to know whether a particular piece of furniture has flame retardant chemicals or not.
Republicans as well as Democrats support labeling these products despite intense lobbying, opposition, and misinformation by the representatives of the chemical manufacturers.
Tactics are very similar to what we've seen with the tobacco industry. Fear, confusion, and straight out deception and lies. Our state legislators were actually lied to by a burn doctor that they brought to give testimony about a burn victim that he never in fact actually treated.
They'll stop at nothing to obfuscate, to confuse, to misinform, to defeat any effort at rationality.
I'm actually very positive that we are moving in the right direction and that there's going to be change and that we will soon be able to have products labeled with whether or not they have flame retardants.
It's about education, raising consciousness, better informing consumers of the concern they should have for the toxins in their homes and what they can do about it.
It would at least put it out there and make people think. Provide the information, whether they use it, that's up to them, but it should at least be put out there.
So this video was produced as part of an earned media campaign, which was one stool in a package of a few stools, if you will, metaphorically speaking, that we used as 1019 moved through the legislature. It will be a reality. Labeling will be a reality because shortly after this video was produced, we were successful in sending SB 1019 to the governor, who in fact signed that bill into law, and it took effect this past January 1st. So I'm pleased to report that tidbit of news. In short, what 1019 does is it modifies the existing label that you find typically on the bottom of upholstered furniture. And it modifies it in the way that you see on the screen here to add one key piece, and that is basically a disclosure provision where manufacturers have to mark a box with an X indicating whether or not they used added flame retardants in the course of manufacturing that particular product. The idea being that if we inform consumers as to whether or not toxic flame retardant chemicals are being used when they're looking to purchase a piece of furniture that it's an intimate purchase. I mean, couches You don't go out and buy a couch every 2 years. Couches typically are with you 10, 15, 20 years. Oftentimes you pass them down to your kids when they're getting ready to move out for the first time. I mean, they're generationally, with us. And so the idea being that now that consumers have the ability to be informed and make an informed purchase decision, that they will choose a healthy purchase decision. And what that does long-term is, as we hope, will reduce the level of cancer-causing chemicals that our members, that you are all exposed to. So as the video mentioned, as Senator Leno, the author of SB 1019, mentioned in the video, chemical lobbyists spent millions in California alone, specifically trying to prevent any changes to the state's flammability standard and or the use or ban of flame retardant chemicals. Their tactics ultimately have resulted in a number of stalled legislative efforts over the course of the last 6 to 8 years, but the political and policy landscape shifted dramatically, starting with 2012, some events that occurred, and I'll highlight those on the next slide. But I think as far as SB 1019 is concerned, it's important to note that Republicans in California, as well as moderate business Democrats, I would say, that ultimately support firefighters, generally speaking, we're particularly swayed by the exposure risks that these toxic chemicals present. And because 1019 was about disclosure, more so than it was about outright banning these types of chemicals, lawmakers seem to be more comfortable to allow retailers to move the market in whatever direction they found most advantageous, while at the same time doing their part to hopefully protect firefighters and the general public. And we're starting to see that goal play itself out. Just as recently as earlier this month, we learned that a major manufacturer of upholstered furniture, Ashley Furniture, has voluntarily said, we're just not even touching chemical-laced furniture from here on out. Kaiser Permanente announced, while the bill was moving through the legislature, that they would stop buying furniture laced with toxic flame retardant chemicals. And those are just two examples where, the market is helping sort of self-police, self-direct. As a result of going the disclosure route, we felt that, it allowed us to get away from having to make the argument about the passive effects of chemical flame retardants in our environment, unlike previous legislative efforts on the banning side. And that seemed to prove successful. So this last slide, I just wanted to touch on a few of the other sort of core milestones, if you will, that help shape or reshape, if you will, the political landscape, which ultimately laid a groundwork of success for us, both on the regulatory side with TB 117/2013, the new flammability standard, and then also on the legislative side with SB 1019. I think the first domino fell when the Chicago Tribune published its highly acclaimed investigative series, Playing with Fire, that documented the deceptive practices used by the chemical manufacturers for years in their effort to keep their toxic products on the market. And you probably have all at least heard of the series, the investigative series that was published, or read it yourself. And then a month later, I mentioned earlier that our governor directed the state regulators to take another look at the old flammability standard and revise it. That happened in June of 2012, so that was another major milestone. And then in October 2013, Toxic Hot Seat was initially released. And I saw on the agenda you all had an opportunity to screen it if you hadn't already seen it last night. If you still haven't seen it, I encourage you to do so. Last time I checked, it was still on demand on the cable providers here on the West Coast. It's a great documentary. And then in August of 2014, I mentioned Chemtura decided to sue the state of California to overturn the new standard. Literally the day after we were successful in sending 1019 to the governor for consideration, we cleared out of the legislature, the court ruled on the Chemtura decision and ruled in favor of the state and shot down Chemtura's argument. So it was the sort of final in the 1-2 punch that we got that week on the flame retardant front. So those are about two examples which, although relatively new, I think we will see play themselves out on a national scale over the course of the next year or two. And they're definitely, we feel, steps in the right direction. There's more work that needs to be done on the proactive policy front, and we're already looking at ways this year that we can build on those successes and continue to make great strides. Thank you.
Thank you, Amy. We're going to move into questions and comments now. But before we do, I'll just mention Toxic Hot Seat will be shown tonight from 7 to 9 in the Pacific Ballroom just across the hall. So those who haven't seen it, if you're here at the conference, we're going to stream that tonight between 7 and 9. For those in the live stream, if you would like to view it, it is available on HBO On Demand. Simply go there and watch the documentary at your own leisure. For those who want to have a copy of the presentations that we used and the many handouts that are associated with this workshop, they will be available on the post-conference website once you return from ALTS. But please give us a couple days to get those uploaded. They will be available online. So I'd ask as you come to the microphone, if you have a specific question for one of our panelists, then simply state your name and identify the panelists and ask your question. If it's a general question and you're not sure who should field it, then just direct that towards me and I'll direct one of our panelists to answer it. So please.
Yes, Alex Forrest from Winnipeg, Manitoba. Thank you very much for a great presentation. Tremendous information. One of the things that's occurring is there's still many states and provinces that are still fighting to get presumptive legislation. And I really believe that one of the paths to getting legislation in many of those states and provinces is through the World Health Organization and the research and the material being put out by IARC. IARC, the last time they looked at firefighting and cancer was in 2010. At that time, there really wasn't the information that there is now. And I think that's one of the reasons why they gave such a low classification for firefighting and its connection to occupational cancer. Given the fact of the tremendous amount of information that's come out in the last number of years from NIOSH, the Korean study, the Nordic study, the Australian study that has come out, my question is for Dr. Weaver, is do you believe there's going to be sufficient amount of information to catch the eye of the World Health Organization and IARC to again look at firefighting to reassess whether or not it should be classified at a higher rate of connection between firefighting and cancer?
So that's a great question. IARC definitely revisits their opinions and upgrades exposures to higher levels of carcinogenicity as they see warranted. And I don't know if they have plans at this point to revisit firefighting, but I know the NIOSH study is very important in that regard, and phase 2 will come out this year. And the Australian data will also be very helpful when that's all formulated. So I think that there's a lot out there to give them a reason to revisit it. Now, I know you were at IARC this year, and so you may have a sense for what some of the criteria would be for that to occur as well.
It's a great question, and we're obviously going to continue our efforts to influence IARC and present as much information as we can on firefighter exposures and how it leads to these horrific diseases. Our next question, please.
Good morning, Jim. Mike DeBron with Local 1014 and the Firefighter Cancer Support Network. I'd like to ask you and or the panel, how can we better effectively communicate the reporting of cancer in North America to get a better database? Because I think really if we get all the numbers throughout North America, and Alex can comment on this, the numbers will actually succeed #1 over cardiac deaths amongst firefighters. And also, I applaud you guys. Thank you very much for promoting this, because 10 or 15 years ago, we never even thought about talking about cancer issues in the fire service. And in my heart, it's the #1 issue that we should take annually and have a safety stand down and promote a proactive approach regarding cancer in the fire service.
Mike, that's a great question. And before I answer it, though, I just want to point out to those who are watching this via live stream and here in the room that Mike DeBron is also the founder of the Firefighter Cancer Support Network, who we've partnered with over a number of years to help provide support to our members and their families who contract these horrible diseases. And Mike, we just really appreciate the partnership and the work you've done for our members. And not only the founder of that organization, but also a cancer survivor, so very passionate about this subject. But Mike, you're absolutely right. Data really does drive everything. And how can we accumulate more data to more effectively communicate our position and our need for prevention, detection, and treatment for cancers. And recently at a meeting I was at, the challenge was posed by us to the other fire service organizations. When are you going to start recognizing cancer as an occupational disease? So we're going to legislators and asking them to pay for presumptive coverage. We're asking them to cover the medical bills associated with this and lifetime benefits for the survivors, yet none of these organizations are even recognizing it as a memorial fact, nothing else, nothing monetary, is an occupational disease. And I'm happy to report that NFPA, who's one of the largest reporting agencies on firefighter injuries and fatalities, is now going to take up the collection and reporting of occupational cancers for firefighters. And that's a huge step to start gaining data to show that this is a real problem with firefighters. So it's a great question, and that's just one step in the right direction.
Thank you very much. And for those of you, I hate to add a workload to Amy's desk, but California Firefighters Cancer Presumption saved my life. And what they've done is the benchmark for the fire service around the world to provide. And if I can, real quickly, Jim, a firefighter came up to our booth from Truckee Meadows Fire Department. Clint Hayes tomorrow is celebrating 5 years cancer-free. So I'm just going to give him, if I may, a coin acknowledging his survivorship. So thank you very much.
Fantastic.
Local 1433 Pascal. This question is for Dr. Weaver. I read some literature about synthetics causing or increasing cancer with firefighters compared to ordinary construction like woods and cotton. My question is, how is the synthetics increasing the cancer for firefighters nowadays with the modern construction? And how is it affecting the body at a chemical level, affecting the DNA and the cellular structure? Why is that happening? And is this true?
So that's really important. The components that burn now are much more complex because the products we have in our homes are much more complex. So it is those synthetics now that create even a wider range of combustion products. So that's the concern, is that going forward, smoke is more complex than it ever has been before. It's true that the personal protective gear is also better, and we've made that a huge effort, but what the exposures are is more complex. And when you saw Larry's slides where he talked about formaldehyde and benzene, and a number of these products are combustion products, meaning that when those synthetics burn, that's what they create.
Okay, so out of those groups, it seems like the percentage of cancer has increased from like the group, was it group 1A that he talked about? Group 1?
Group 1 are the known human carcinogens.
The known, so those are from the synthetic combustions, right?
A lot
of them are. So how is that affecting the cell much more stronger than the other groups, or from the older combustion or older fires?
I think in terms of data, exposure assessment is one of the biggest challenges. And so very few studies have the numbers to go back and say, did the types of cancers change dramatically from 1960 through 2010? The NIOSH study is working on that. They're attempting to do that, to look and say, okay, as exposures change, did the types of cancer change? But again, when you do that, that gets much more difficult. So in their study from 2013, they do have a bit of data where they've tried to look at decades to look at that.
Thank you.
Mark Davis, Local 145, San Diego City. Thank the panel again. Another awesome presentation. Jim, I think I'm going to throw this towards you a little bit, and maybe Amy from CPF can help a little bit here too. We've been talking about the data collection at our department, particularly with some of our relief folks, on how we can better improve our collection, so when we go in front of retirement, medical retirements and things like that, we'll have something, hopefully a stack or a 3-ring binder where that individual can put down in front of them and basically say, see. And CPF has a data collection. I'll be honest, I don't know if Lou and Lou are in here, but I don't think it's really, hit the stars as we had hoped. Is there something maybe from the IAFF as far as software solutions? We do have 30 states that are, cancer presumption, which you've indicated here. So maybe that's a good start when we only have 50 or so states here. We're pretty well going there. Is there a software program, maybe the IAFF, in a way, lack of a better term, sponsor or figure out who can work with us as a larger 300,000 IAFF members? I think CPF's offering $15 a head for each person that wants to enroll, and that, when you got 1,000 guys on the job or more, that starts to add up. Or when you're a small job and you're fighting as many wars that we are, it gets difficult.
Absolutely, and I'm going to answer your question in two parts. First, from the IAFF and our efforts, we are in fact developing a cancer awareness prevention education module that's going to be available online, and it will include exposure reporting and downloadable forms that you can use for that, or at least modify for your particular jurisdiction. And I'll let Amy answer for the California side, because the form that we're creating, a more generic version of what California does have. So Amy, if you would comment on that, please.
Sure, and I would just note for California's PER, it's not specific to cancer-related exposures. It's, it's a system that is as good as the user is honest in reporting, after a particular call. So there are a couple of things, just to make clear on that point. And then, more recently, we've had success with the state's commission on workers' comp and health and safety and the studies that they have done specific to California. And I think Jim had mentioned that the materials that the panelists compiled here today are going to be available online after the conference.
Yeah.
That study that I referenced during my presentation will be one such resource that you can download off the website.
Okay. Yes, sir.
Yes, Bill Ramaka, 1st District Vice President. I just wanted to say with the World Trade Center program, that part of the problem we had in proving cancer was the degree of proof that was needed for a place like NIOSH, federal government, and everything like that. We ended up having to do was compare the medical evidence with the tumor registry. And part of the problem with that is that's 3 years behind. So it's just, everybody thinks that it's easy to prove. No, you really have to document this stuff and go in, totally involved. And different studies do a different job of documenting it. And my other point is, and I'd like to ask Dr. Weaver about this, is we've actually found that the PSA with prostate cancer, now it was more important about the difference in the tests from one number to the other, about whether the chance of prostate cancer was more involved with our patients. Do you subscribe to that theory of what we found?
So I think that's an important point, the idea of following PSA to see if it in fact increases. It remains very controversial, though, the best use of PSA, and the authoritative agencies are really kind of pulling back from the recommendations that they made. So, in Wellness Fitness, we're recommending a discussion with your individual healthcare provider, and this idea of following levels along can certainly be one response to that.
I appreciate it. I appreciate the panel's work today. Thank you very much.
Thank you. We'll entertain one more question, then I'll ask the General President to come in and provide closing remarks. Yes, brother.
Yes, Robert Campbell, Local 867, Winnipeg, Manitoba, Canada. And I just recently had the opportunity to attend the conference in Bergen, Norway, where they don't have presumptive cancer legislation. And just to add to Larry's presentation, whether they attend, particularly in Sweden, whether they attend a house fire or if it's overhaul or what have you, even in the extreme temperatures, they're outside. They do not get in their cabs. They take their turnouts off right down to their underwear. Their blues, their station blues are gone. Dress outside, no carcinogens inside the pumps whatsoever. Their clothes are bagged and put away for cleaning. So I just wanted to add that too, and looking forward to the study, what carcinogens do we have inside our cabs and what do we carry?
Yeah, thank you for the information.
Yeah, those are excellent comments and definitely things that we're going to include in our online education program too, because they are taking extraordinary steps on the preventative side. So I really want to thank the panelists, and I'd ask the General President to provide some closing remarks.
Jim, thank you, and to the panel, excellent presentation, really informative, helpful, something for all of us to build on. I want to thank all of our leadership in the workshop here in Anaheim, but I really want to thank our leadership and those across the United States and Canada who have joined us through this live streaming webcast for this workshop. I'm told that we had another approximately 1,200 individual visitors. We had several hundred that stuck with us throughout the entire presentation. We've already received responses from stations in both countries that have been watching it in their stations. I would ask the viewers to let us know how this worked for you. We're looking for a way to expand and to push out more and more resources, tools, and services from this IAFF to our leadership across 3,400 locals that can't always be in the location where we hold a forum. So we're going to use this live streaming broadcast more often. But if you will, you can give us a review. You can tweet us at #ALTS15. Go to our Facebook site, post it. Let us know how valuable it was, useful, and we're looking forward to hearing back from you. Again, to the panel, thank you so much. Jim, Larry does such an incredible job in our health and safety department, and for all of our leadership, hopefully we have given you something to take back home and to make a difference. Okay, we'll close.